Thank you, Ronnie. And I would like to thank Sibel and Samira for covering my topic as well. So we all know that the hyperemia is a menace, especially with the anti-glaucoma medications or any chronic therapies in the ocular surface definitely causes more damage. So we know this kind of eyes, it's not uncommon to see in our glaucoma practice. So most of the glaucoma medications, or at least many of the glaucoma medications, does cause this problem. Though it has its own effects, therapeutic effects, but we need to understand the side effects. Especially, there are many published articles on the anti-glaucoma medications and on the ocular surface, how much it can really damage the ocular surface. So just look at the definition of hyperemia. It is increase of blood flow, that is engorgement of the conjunctival blood vessels is the definition. So what is the actual problem that we have? One is the cosmetic problem, that is the ugly looking eyes, which probably leads to non-compliance in many of our patients. And of course, there is an increased overall cost in patients who are treated with the not only the PGAs, whatever the medications which causes the more adverse events. There is always an increased cost. And of course, what is that which really bothers me is the compromised outcome on the filtration surgeries, that is the trabeculectomy. So looking at the hyperemia evaluation, we have definitely some limitations. There are conflicting results and the bias. So just to look at, one is the color based. So overall redness we look at and then say how much is it mild, moderate, or severe. The other way to look at is the vessel morphology, means that is the area occupied by the vessels, the number of vessels, the diameter, and the tortuosity, and etc. by using some of the algorithms by various people. So this is the hyperemia severity grading scale. There are multiple severity grading scales are available. You can see that VBR, that is a validated bulbar redness scale, IER, IFRAN, and then menace. And of course, we have something from the Japanese as well, that is the Ocular Allergy Society grading system as well. But the problem with all this is the high intra and the inter-observer variations. So there is a bias in this actually. So what is the best way is to go is the hyperemia analysis software, which looks at the proportion of the blood vessels. This is the software which is available, and currently it is being mostly used for the research purpose. But this is one of the best softwares that you can use it to see the hyperemia grading. It is much more convenient, more accurate, and then it has a very less bias. So just to show between the two systems, one is the clinical grade, and you can see on the right hand side is your pixel coverage value. So this is the software based, which is much more accurate. So how do we really evaluate the hyperemia in our practice is much more simpler, looking at the conjunctiva, looking at the blood vessels before and after starting. This is kind of a mild. Then we call this as a kind of a moderate congestion or moderate hyperemia. Then of course, obviously we know that this is a severe hyperemia. So these kind of patients obviously is not going to use the medications unless there is a very advanced glaucoma and then you are forcing them to use. Even these people might be just missing a few of the drops. So we have seen why we are concerned about it. Of course, all the three problems which I've already mentioned. One is the cosmetic problem. Then there is overall increase in the cost. And of course, the compromised surgical outcomes. So when you're looking at the side effects of these medications, as Dr. Sibel was showing, the side effects of the glaucoma medications could be as high as 42%. But when you're looking at the hyperemia alone, about 27.4% of the patients were kind of discontinued their anti-glaucoma medications, which we all know what is going to happen. The discontinuation is going to cause uncontrolled intraocular pressures with the progression of the disease. So the long-term treatment with the anti-glaucoma medications, how does this cause the surgical outcomes altered. We know that we have enough of medications like beta blockers, CAIs, alpha agonist, and so on. But then not a single medication without any adverse event. Almost all the medications do have some amount of adverse events. Just looking at the beta blocker versus prostaglandin under control, the beta blocker seems to have a little less hyperemia in comparison to the prostaglandins. Obviously, we all know that. In clinical practice, we all have seen that. Looking at the Indian market, the tafluprost is a new entrant, and all the other three molecules were already there. So looking at this table, you can obviously see that the tafluprost has probably the lowest amongst all the prostaglandins in inducing the hyperemia. So you can see that when you're looking at the other three PG analogs, which are already there, the bimetoprost seems to be having a slightly higher than the travoprost, and the lowest being the latanoprost. When you're looking at the combination with the latanoprost, it is not that you don't have any problem with the latanoprost combinations. Of course, you can see that the lowest hyperemia incidence in a combination seems to be with the latanoprost brinzolamide comparison. Though this molecule is not available, the ripasidil, omidipinag, whatever I tried my level best to pronounce this, but somehow I'm not still getting this in my mouth. So you can see that obviously the ripasidil still has the higher incidence of hyperemia. So what really happens when you use the anti-glaucoma medications on the conjunctival surface? One is it induces the conjunctival inflammation, and also it alters the cell structure and the cell counts. So what is that we really look at when you're looking at these specimens? So we have to look at the cellularity, we have to look at the cell-to-cell junction, nuclear cytoplasmic ratio, how much it is altered, and we have to look at the chromatin levels, raw blood cell distribution, how much of the keratinization has happened, and also we need to look at the inflammatory cells presence. If you get a score of more than 4 to 6, then obviously the conjunctival cytology is completely kind of altered. These patients, we can kind of say that these are the patients going for the failure of surgery. So these are normal cells, you can see, and you can see how abnormal this has become. The conjunctival cytological changes, especially the 100% change in the nuclear cytoplasmic ratio with the inflammatory mediators being there. So this is a patient who has been done, who has gone through the surgical procedures, multiple procedures. You can see there are 2 bleb areas, and you can see the hyperemia as well, because this patient is on PGs and also other anti-glaucoma medications. So it's not very comfortable for the patient. So looking at the hyperemia associated costs on the medication changes. So these are research methodology. This is one of the big studies, like they've included about 8,743 patients who are on the PGM monotherapy. And these are physician-reported rates of hyperemia were obtained from the chart reviews of about 300 patients. So if you just look at this, the hyperemia-free patients versus the discontinued initial therapy due to hyperemia patients, there is a significant increase in the cost. That could be because of stopping one PG to another PG, change over to another PG, calling them for follow-up, then treating them for their hyperemia. So there is an additional cost which is involved in this. So there is an add-on cost for this. So the hyperemia results in, there is an increase in the overall cost for the patient. So looking at all the 4 PGs, we always think about hyperemia. What is the reason? Is it the molecule as such causing the effect, or is it the preservative? If you look at the tafluprost being one of the PGs, it has the lowest concentration of the molecule and also the lowest concentration on the BAK. And so that's the reason, one of the reasons why the incidence of hyperemia in tafluprost is much lower in comparison to all the other PGs. You can see in this slide as well, all the 4 PGs are given, and I can see the lowest incidence being with the tafluprost. So just to summarize, we all know that we all have to start on anti-glaucoma medications. But effectiveness of IOP lowering is not enough, but we need to concentrate more on the quality of life, like what Sibal was mentioning earlier, and its associated side effects, how much it can alter the outcomes, like a surgical outcomes or the ocular disease, ocular surface changes, how much it can cause. We need to think overall for the patient's quality of life. So I would like to acknowledge Mr. Gyan and Mrs. Rajashree for helping me in preparing my slide. And I would like to appreciate all your attendance. Before you have the redness in your eyes, I would like to sign off. Thank you so much.
Thank you, sir.